Welcome everyone for coming to MHAM's webinar. Today we are focused on OBRA and trends in geriatric mental health. Today we have with us Kathleen Faber, and she is a licensed mental health counselor who started working in the field in 1987. Her work has been focused primarily with older adults over the last 15 years. She has a specialty in substance abuse treatment and is committed to making a difference with her day every day. At the age of 3, Kathy was in a fire and rescued by a 12-year-old neighborhood boy. And Kathy's experience with this and his has inspired her with her choices and decisions that have shaped her life. And here's Kathy Faber with us to tell us a little bit more about herself and her presentation. Thank you, Kathy.
Thank you, Kristen. Good afternoon, everybody, and thanks for attending today. You know, the inspiration from the 12-year-old boy carried on throughout my childhood, and with him telling me that I needed to do something, you know, special with my day. So that is kind of and special with my life and making a difference. So and you know, it kind of sat with me for, you know, obviously I'm 62 now, so it's been like resonating for quite a while now. I've worked in the field for a very long time and feel very I guess fortunate to be able to do what I do and have had just to have the experiences I've had. I saw the attendee list and I didn't see any names that popped out at me that I knew, but I've had just a wonderful career working in substance abuse and then inpatient and outpatient and worked in mental health with the local CMH here in Lansing. And I've also worked with the Red Cross and had some wonderful experiences with that. And just a little tidbit was that I was one of the shelter managers for the Houston Astrodome during Katrina. And that really had a positive, and I say positive because the experience was reported as very negative, but you know, it really made a difference with my direction and what I ended up doing and where I'm at. So anyway, that's about me, and I do try to make a difference with my day. I tend to be a half cup kind of full girl, and hope that kind of comes through with what we do. I'm going to talk today about a little bit about OBRA, and that is where I've been at working and focused in the last 8.5, 9 years. And I have been with the state OBRA office for the last 4 years, but I was with the local community mental health at CEI prior to that. And OBRA, most people have no clue what OBRA is, or it's also called PASRR. And so I'm going to start my screen presentation, and I'm a short girl, so I got to look over my open laptop and hit the right thing here to get it going. Maybe. Are you guys all able to see my
We see your face right now.
You see my face. So, oh, I know what I didn't do. I got to share my screen, don't I?
Yes, ma'am.
Technicalities. Let's see.
Perfect.
Are we seeing it now? Good.
Yes, ma'am.
Yes, yay. I primarily operate off from Microsoft Teams, so whenever I get into Zoom, it's always a learning curve, so I apologize for that. All right, here's OBRA and PASRR. They're kind of intermined, and we talk about them interchangeably. Some states use PASRR, and you know, when you say OBRA, they're like, "What is that?" And OBRA is just the acronym for the Federal Omnibus Reconciliation Act of 1987, which is where this all started. And PASRR stands for Pre-Admission Screen Resident Review. The Office of Specialized Nursing Homes, which is where the OBRA programs live in the state of Michigan, started in 1991. And of course, the Reconciliation Act was in 1987. So a few years later, we started. And really, it came from the Nursing Home Reform Act at that time. So it's where we all started. And there was, back in those days, there was a lot of issues with a lot of the state hospitals were being closed, and a lot of individuals with IDD disorders and diagnoses were being kind of what they call warehoused in the nursing home setting. So that's where a lot of this reform came from. And, and one of our big goals is to ensure that people with a mental illness or intellectual disability, that they are in their least restrictive setting, if possible. And then, of course, always, looking at their needs, their wishes, as far as what type of setting they want, and their guardian. So we really try to make sure that it meets those desires and those needs of that individual. And I'm dying to ask, are there very many people out there that have heard of OBRA before or know about OBRA? I know there's got to be a raising of the hand kind of, process.
Raise your hand or drop it in the chat.
I would love to know how many people know about it. Like I said, most people do not know anything about OBRA. So they say, what? So what is it? What are we trying to do? We're really trying to ensure we do what we call a pre-admission screen. That's our primary. We kind of call it a PAS. And we also do in Michigan an annual review. And we really look at every individual that goes from like a hospital or community setting, that they are going to get their due diligence, and somebody's going to do a triage of their care needs and whether or not they need that level of care. And then from there, we even look at it even a little more deeper. So, and I'm going to go through some of these slides because I'm just going to kind of ad lib as I go along, but they kind of explain the system and what we have to do and what we're looking at. We look at these individuals and we determine, again, the most appropriate setting for them, the level of services that they need mental health wise. And we have a lot of our OBRA coordinators offices, which are primarily from CMHs around the state, but there are some contracted providers out there that provide our OBRA services as well. But we also then look at, do they need specialized mental health services? Do they need specialized OT services? We have that in some of the areas around the state that provide those services for our IDD folks. And we look at this, and I mentioned we do this annually every year. So if the individual stays long-term or stays longer than a year, then they're required to do another referral, the nursing home is, and to send that in to the OBRA coordinator, again, go through that triage. They also then have we'll end up having to do what's called a full level 2, which I'm going to go into a little bit. So that referral process starts with the 3877. And this form it's a pretty much a one-page form, and it identifies, there's 6 questions in it, has a demographic information, 6 questions that identify or indicate any presence of mental illness or IDD related conditions, that type of thing. And that's where it all starts. And so the process right now is electronic. We went live with an electronic referral system in the fall of 2021. And that was quite an undertaking by our office, I have to say. We're still dealing with a lot of issues and things that have come from that, but overall it's been a very successful transition, and we feel pretty proud of what we've been able to accomplish with it. So that level 2 or level 1 evaluation referral process starts with that triage from the OBRA office. And then once that is done and they determine whether or not that it needs to have that full evaluation, that level 2 we call it, then they will have the assessors go out, they do a face-to-face interview, and that face-to-face interview is comprised of several different facets there. And I've got those in a slide too, but there's a psychological. For an IDD person, there's a psychosocial that everybody gets. There's a medical evaluation that everyone gets. There is a OT eval that is just for the people with intellectual disabilities. And then there is a follow-up coordinator's report with the recommendation, overall recommendation. And when they do all that assessment, these can range probably on an average of about 16 pages. And so it's a very comprehensive evaluation process that is done, and gathering of information and of historical information as well as current. And then with that, when they finish it and send it into our office, our clinical team completes the process with the final review and determination. And again, that determination is going to include what level of services, mental health services they may need, or if they qualify for ongoing nursing facility care. So these are those assessments that comprise the level 2 evaluation. And, and so that process is done in every state across the nation. And a lot of the states are going to an electronic process. We just got contacted recently by Arizona, and they're in their transition of doing the same. And so it was interesting because about 7 or 8 years ago, when we started the process of ours, I was part of that in talking to other states and how they are doing what they're doing. And I wanted to, kind of share how we decided to come, do our electronic system and maintain our relationships with our stakeholders, with the CMHs and across the state, is that we really felt that the personal touch, the face-to-face interviews, those types of things, that those were very important to the outcomes. And so we built the system so that it would really reflect what the needs of that individual really were. And I personally feel very proud of the system and what we've been able to accomplish with it, and feel that we do a really good job. So now I want to talk about some of the changes and some of the trends. It's one of the biggest things that we've seen is the age changes, and whereas when I first started with OBRA about 8 years ago, the ages are different now versus then. So we very rapidly have the age group that we're seeing starting out is in the 50s, and we're seeing a large number of those. And since I was doing this setting up to do the webinar today, I've really paid attention to the reviews that I've been doing and determinations and looking at the ages, and they are primarily 50s and 60s. I mean, once in a while I'll get a 79-year-old, and every now and again there's somebody that's older, but not very many. It's we have them, but the majority are 50s and 60s. And this age change really tells us a lot of things. One of the biggest things is that, we have a bigger group of people moving through, which, we all expected. The baby boomers are moving, and we knew that. And we knew that this was going to hit. And I think with COVID, though, the timing of it all has not had the most positive effect on how we deliver services and or what we're able to do. It's not so much not knowing the right things to do, but it's having the right tools in order to do the things we do. And, with staffing shortages and stuff that have, really been a prevalent factor, over the last few years, we have really, really seen just huge issues and problems that are going on. And this slide just talks about, the larger group of people moving in, and a notable increase in the severity of mental illness. And I have to say that one of these issues is really about, as people age with severe mental illness, say schizophrenia and different things, they tend to mellow a little bit, you know, for the most part. At least the people that we normally see move through the nursing facility care side of things. And they, you know, right now we're seeing more 50s and 60s, and they have not, there's no mellowing yet. And so we are seeing a lot of very severe, you know, aggressive kinds of behaviors, and that really are detrimental to going into, you know, a nursing facility type of setting. And it's kind of hitting everywhere, and it's having this, you know, effect on, you know, the emergency rooms and a lot of different places where care is being given. So some of these challenges is that, you know, there's been, you know, a lot of closures in what we would call, or what we termed, specialized adult foster care homes. A lot of these specialized homes were run by the community mental health around the state. And there's been a lot of closures, and a lot of it has to do with staffing and not being able to staff to the degree that is needed to handle and you know, effectively deal with these behaviors that are being presented. You know, and a lot of these places, they really, when they make referrals, the individuals meet a nursing home level of care. However, behaviorally, it's not a good fix. It's a huge risk, you know, to put somebody in that setting, and you know, and it just creates a vulnerability both to them and to people that might potentially, you know, get harmed. So, you know, what do we do? You know, and you know, how do we make this continuum of care, you know, work for everybody, for the needs of everybody we're seeing. I did hear the other day that there is going to be some creation of a higher level specialized AFC in the state. There's only, I think, the okay for 60 beds, which I think 12 are geared for children, and then 48 for adults. Those probably primarily will be referred probably through the CMHs, which I don't know if some of the folks that we work with through OBRA, if we're going to be able to have some say in that and access to those beds or not, but it'd be wonderful. And I'm going to tell you a story about a gentleman who, just to kind of give you a picture of what we've been dealing with. And I know these are some of the things that I deal with personally. But we had a gentleman who had a diagnosis of autism, who had, and historically had been pretty independent, came from a very supportive family, which means a lot in these circumstances. That's not always the case. But in this case, he drove a car, he read, you know, and did some workshop work kind of things, but had supports in the community, but lived on his own. And had a really good, you know, things were really working well for him. And he started to have some dementia related types of symptoms. And so he ended up with a diagnosis of early onset, and the dementia really affected his ability to, obviously, he lost his driver's license, his ability to drive. He started having some other, just, you know, I mean, with autism, he had some stranger behaviors, or at least how he presented to other people. And he had an incident where he went in, he had a routine, and those people that are used to working with people with autism, they're very routine. And every Friday he would go in and have lunch at local kind of pub place, and where he lived, and he went into the wrong bathroom. It scared the person that he went into the women's restroom, and it scared the woman that was in there. She came out all upset. Her significant other severely beat this individual up. And so it was just a huge trauma. That trauma started a spiraling effect with him and going down. And he ended up in a specialized adult foster care home after that. And there was some issues that they had there. And then he ended up in a nursing facility in the Detroit area. And And it was a rougher type of, because of the behaviors, he ended up there. And he ended up having some medical issues, was sent out to the hospital. And when he went into the hospital, he was described as walking like a crab and not being able to really verbalize very well, very mumbly, very just not making nonsensical type of verbiage. And he ended up being in the hospital for about 9 months because there was no place for him to go. And however, my hat goes off to the hospital and the staff there, and I've commended them for everything they've done. That man walked out of, after 9 months. We worked on placement. We found placement for him. It took a while, but he walked out of the nursing home. And was talking again, and was reading the newspaper, doing some of the things. And the thing that he gained most was that he was able to recognize his parents again. Because he went a while, when he saw his parents the first time when he was in the hospital, he screamed out, and he's like, "You aren't my parents. My parents don't look like you," but when he saw them again, and they stayed away for a while, and it was a wonderful thing to see all this happen and come together. But what happens, why he was in that nursing home so long, is because he had an OBRA evaluation done, but he got a no for nursing home level of care. And it was because of the risk that he may have had on the residents there, and some of the aggression that he had when he first admitted to the hospital. And so it took a while, but he is in a specialized adult foster care home now, and he's doing really well. And these are some of the cases that we're hearing. So it's not, this gentleman had an intellectual disability, but we see far more behavioral or MI individuals that are waiting somewhere. And we have a lot of people that are waiting in a hospital, just waiting for a placement. And it's sad to see some of these challenges that have happened, and a lot of these are really spearheaded by staffing challenges. And a lot of the nursing homes that we worked with in the past with our behavioral individuals, they don't have the staffing to maintain or to ensure good care. And there's been such a high turnover rate as well with some of the staffing that they have, that the training isn't there as well. But some of the facts that numbers that I've put together, and I got some of these numbers from Michigan Hospital Association, but it starts usually, a lot of our referrals start here at the hospital. And we have, they gave me numbers over the last several years, and they're maintaining right now, we're right around 30% of those individuals going into an emergency room, emergency department, seeking care, have a diagnosis of either MI, IDD, or SUD, which is substance use disorders. And we see a lot of that mixture of all three, or two, or one, or the whole bag. So 30% equates 886,000 people in the last year going through an emergency room with a mental illness diagnosis. And 55% of all inpatient admissions come from the emergency room, have that diagnosis of MI or IDD. And one of the things we've been working on fairly recently is really looking at the ER situation and the crisis situation that they are all in with having beds. And, this 55% that all end up inpatient, there's not always beds for them to get into because of staffing issues. And so they stay in the ED and wait. And what we're really seeing is we're seeing a lot of people in the hallways and, on a gurney bed. And, for our folks that with a mental illness or an IDD, it's such a triggering, environment for them, because there's so much chaos going on, and sounds and noises. And so it really is a crisis, not just for everybody, but but especially for our folks that we work with. And this just kind of, one of the things, I talked with Robin, who is our OBRA coordinator for Detroit Wayne. And they work, she doesn't work for Detroit Wayne. They contract with Neighborhood Service Organization, and that's where Robin works. She works out of there, and they cover both Oakland and Wayne for OBRA services. And of course, you can imagine their numbers are higher than anywhere in the state. But, I usually, when I'm looking at information, I talk with them, and her biggest issue is that high acuity level of MI that we're seeing, with aggressive behaviors. And she said one of the things about this population is also that we're, psychiatrically, it's very difficult to stabilize and their symptoms, and it's just not happening. And, on the other side of that too, we have so many people that get sent out from a nursing home, if they're already in a nursing home, that are presenting with, suicidal ideation or an increase in, psychiatric behaviors, aggression, that type of thing, that get sent to the ER to look at psychiatric hospitalization, and they get sent right back because there's no beds. And it's like this revolving thing. And, and I hear that all over the state. That's everywhere. So, it's a very huge issue. And, these individuals a lot of times have very significant medical issues that need to be addressed in, a medical care setting. And so, such as a nursing home. And, a lot of times, again, they aren't finding beds. We have a lot of nursing homes, even though they're not supposed to do it, but they will refuse to take the person back. And even though they know they'll get a citation for it, they'd rather go through the citation than put other people within their facility at risk. And it's a huge issue. And I know I keep saying huge issue, but it really is. And I think that we really have to look at everybody's safety and security, not just the individuals in the nursing facility, but also individuals that are in question here. Just to kind of give you some numbers, I ran some of ours. So in 2021, 2022, we processed over 24,000 referrals, and that is that level 1 referral form that I talked about. And these are all electronically done, so we captured every one of them. And there's probably a few out there that we didn't. The community providers are not electronic yet. We're looking at bringing them on board in the next year or two. And however, 24,000 is a huge number. So, and one of the issues that really, has been a big deal is how well trained are the staff, to really, deal with severe MI and IDD behaviors. And I'm going to tell you right now, they're not. I think we really, really need to do something to make a difference with training and for our staff, that we have this expectation of being able to care for this special population. And there are a few around the state specializations. Metalodge of Lansing has a behavioral unit. And so they've got some specialization, but it's only so many beds. And obviously can't, it would fill up so fast if we could probably fill up a whole nursing facility that size or more. And that's worked well. But even during COVID, because of staffing, they weren't able to do what they needed to do. And they are looking now at CEI and the OBRA program are looking at doing some part-time staffing of case managers that work with the OBRA team that will be on site for certain periods of time. And so that in itself maybe will make a difference with that unit, but I think we need more of these specialty units around the state. We need to have specially trained individuals that work with, are able to work with these individuals. And, and I think a lot of that, there are several nursing facilities, corporate, that are bigger, that are willing to do it. I think we just need to like figure out funding and how it can be done. And but they are more than willing to, partner and do what needs to be done, and be able to work with these individuals that really need care. So what can we do? I guess the first one that I have on my list is becoming an advocate. I mean, it's really important to spread the word. And again, I assume that most of you in the field that are listening today are in positions where you're working in mental health or you're advocating, that type of thing. So I encourage you all to do the best next thing, and see what we can do. Encourage more funding. I've also had talks about special units for IDD, and in a nursing home setting, and being able to deal, because there's special needs. I mean, when you have some of these issues and you couple it with dementia, there are really a lot of extenuating issues that come up out of that need specialized care. And we need to support our nursing facilities so they can deliver that specialized care. I think it's just something that we all need to do. I was in a meeting with our management one day, and we were talking about some of these issues, and we were working with some really difficult. There was one case I worked with that kind of made its way up to the governor's office, and the individual's guardian was you talk about an advocate. And and then I said, if we can't make changes happen, or inspire changes to happen, promote change from our level, then who can? And I think we really need to look at that, and and identify what these gaps are, and see what we can do to make a difference. How can we do that? I talked about this, creating more specialized nursing facility units, for both MI and IDD. Staff education is a huge one. We've been talking about, looking at how we can use some grant dollars to, put together educational RFPs for staff education and in the nursing homes. And it really is something that needs to be done. And on an ongoing basis, the staff population in these facilities rotates quicker than anything I laughingly say, so many of the nursing facilities change names so fast too. I mean, corporate, there's so many buys and sells, it's amazing. And so it's hard to kind of keep track of who's who and what's what. And so it's got to be an ongoing effort to really make this happen, I've been hearing a lot of talk lately about PTSD in the workplace, and especially for people that are providing direct services and direct care. And it is. It is exactly what's going on out there. And that's exactly why we're losing staff like we are. Whether it's nursing staff or mental health staff, or, whether it's a mental health, a licensed, mental health therapist, or it's a caregiver, or who it is, we're losing staff. And, and I think that's the other piece of this too, is that we really need to, build the resiliency and take care of our staff. We really need to have programs in place that do that. And, and maybe with a lot of proactive changes, we can find some stabilization, from this post-COVID kind of situation that we're all in. I say post, I don't know if we're really post yet or not, but we are learning, I think, to cope with some of the things that we've, experienced over the last 3 years. But, we do need to, start somewhere. And so again, that advocate person, I'm encouraging you all to be the initiator in your organization, in your team, to build some resiliency, and encourage people within your team to build it and practice good self-care. And I not only work for the state, I also have a private practice. So I'm a very much, I work too much. Yes, I do. But I really am a believer in mindfulness practice and taking care of yourself, and and often being your own best advocate. I could probably talk on this for a long time, but I don't want to take up the whole time. I want to see if there's any questions or anything that people have. Last but not least is my last slide. Well, almost next to last. Last but not least, we need to respond to this very vulnerable population of individuals with the care, dignity, and quality of services that every Michigander deserves. And I read that because I hate reading slides, but I read that because I think it has the most impact being said out loud. And we all move to the table with great intentions, we do, but we have to follow through. As tough as it is, we have to stick with it, because that's how we're going to get through this, all the issues that have been created with the pandemic. And it's time to create that recovery plan. How are we going to get through this and come out the other side, with a model of services that we need to have in place to make sure that the people we serve get their care needs and the quality that they deserve. So that is my presentation, and just some thanks to some of the information that I based some of my presentation on. And one of the things that I found in the last few years is that there are so many dedicated people out there working in this field. And so I know together we'll all make a difference. When I talked about being with Katrina, or being part of that whole thing, I remember sitting up, this is like day 3, we had over 10,000 people come into the Houston Astrodome. If you can imagine, and from buses, just bus after bus after bus. And I remember sitting in the bleachers, and after my shift, we worked a 12-hour shift, and sitting up there with my team, and team was, there was only like six or seven of us from Red Cross. That was the Red Cross team. But I sat up there, we were sitting there, and I looked around at everybody, and I thought the whole experience just made me realize too, it's what we do together that makes the difference. It's not, individual differences, even though I say that all the time, but it is collectively, if we all work toward making those differences, the outcome is amazing. And I saw it happen there. And I think that was probably the most inspiring thing that's ever happened to me in my life. And, it was a life changer. When I was going down on the airplane for that deployment, I was sitting next to an older adult and woman, and she was a Red Cross volunteer. And I went down as a staff person. I was a Red Cross staff person. And she said to me, she goes, honey, she said, I'm going to tell you, she said, this is going to be one of those stories you're going to tell your grandchildren one day, and she was right, I feel very fortunate to have, these life-changing events that have happened in my life. And it's really given me a perspective and a drive to keep moving in the right direction. So does anyone have any questions for me?
Thank you, Kathy. Actually, we do have a few questions in the chat. So Pat is asking, what is the current level of people with mental illness, IDD, who cannot find placement due to staff not being able to address behavioral issues? And does the state maintain a waiting list?
We do not have a waiting list. It is just a constant, each OBRA coordinator, each, area, CMH OBRA, and most of them are CMHs around the state. So they're in that catchment area, we call it. But we all, we try to work together on these, and and there's I can't give you like a real number, but I can tell you that any given time, there's probably both hands of numbers. There's 10 to 20 people out there in this situation. And those individuals could be mentally ill, or they could be have an intellectual disability, or both. We have a lot of folks that have IDD along with mental illness diagnoses. We're also seeing a large amount of people with head injuries that are kind of getting pulled into this group, and and are being treated for mental illness, even though I think what came first was the head injury. But so it's a tough place. So when we do a no nursing home determination, after we've done a full level 2, which I do the majority of those, I try to do follow-up and try to assist in any way I can, to kind of make things happen and push things along a little bit. And I found that for the most part, most people try really hard. The biggest issue is there's just no place for them to go. They're these AFCs, a lot of the specialized ones have closed, and so there's just nowhere. And the nursing facilities, because of staffing, they really can't take them, even though they would love to be able to do it. I work really closely with Metalodge and Sienna, and those are the 2 biggest corporate groups in the state, and they do a pretty phenomenal job with all of their homes. And I just am like, even they are like, we just can't do it, in some instances. So, because I'll call and say, hey, can you can you do this? Can you take a look at this person? And that type of thing. And they do. And then we try to get APS involved and other services as well. So
okay, she had a second part of her question too, and Pat, you're welcome to jump in as well if you have other comments. But Pat said also, what number of people with mental illness, IDD, who do not have problematic behavior are waiting for placement, and is there a waiting list?
No, they usually get placed. That's not usually a problem. And a lot of our folks, one of the things we can do to help with some of these placements is that, and I talked about specialized mental health services, that makes a big difference for a placement in a nursing home, because and I say we, because I used to do that work myself too, but, the staff, the case management staff from the CMH will go in and provide one-to-one services with the individual. And there's a different variety of those services that can be, maintained. But, one of the things that's most important in those for the specialized services that, that individual that goes in, they review, nursing notes, and they review ongoing what's happening and impacting that individual. So interventions, if needed, can be done right away. And that makes a big difference with, whether or not a person gets sent out to, for a psych hospitalization, that type of thing. Unfortunately, even the specialized services have seemingly been cut a little bit because of staffing on the CMH side of things. So we do see more people. I'm hearing more stories of people, getting sent out to the ER, for psychiatric evaluation, and then being sent back because there's no psychiatric beds.
Pat, do you want to add anything more to your questions or comments?
Yeah, I'm thinking about for people who might want to advocate for increasing beds for behavioral problems, wouldn't it be good to have data about how many people are turned away for placement? And whatever your answer is, if you don't know, where would someone go to get that information to make the case that it's needed and more funding is needed?
Yeah, I definitely could pull together, some no nursing home evaluation numbers. That's not a hard one to do. And some of the individuals, some of them are already in the nursing facility and then get their evaluation. So there's a couple exemptions to going through the full level 2 evaluation from a hospital setting. And one of them is what we call, if the individual is, they're only recommending, the doctor's only recommending 30 or less days of skilled care, then the individual can admit to the nursing home without PASRR. And then at day 25, after admission, a trigger it happens in the system, the electronic system, and then PASRR gets initiated. And so a lot of the no nursing homes are from people that are already in there, but we also have them from, that are in the hospital as well. So we have quite a number of no nursing homes. The no nursing home count, I can tell you, because, again, that's something I do, it's gone up. I do way more no nursing home determinations now than I ever used to. And we're seeing that, that's the recommendation. And again, it speaks to some of the numbers and stuff that we're seeing, with the behavioral problems and that type of thing.
Just to follow up, what do you mean by no nursing home?
So when we do an evaluation and we deem that the individual, and these are the most of these, that the individual is not appropriate for nursing home placement, and a lot of times that is because of the risk that they pose not only to themselves but to the other population in the nursing home because of aggressive behaviors and that type of thing. That would get a no nursing home determination. Mm-hmm.
Emily has asked, how many people with mental illness, IDD, are currently in nursing home settings?
I didn't get that number, so I would have to check, but my best guesstimation, we talk about the hospital, about 30%. I'm going to tell you it's probably very close to that for nursing homes. But it's a number I'm going to look up. I thought about that like this morning, and I'm like, I should find this out. So
if you have any follow-up information, I'm happy to, send it out to the group.
Okay.
Not to put pressure on you, Courtney, but Courtney, looks like you are with Sanilac County and you're the coordinator for over there. Did you have anything that you wanted to offer or comment on with Kathy?
Hi, Courtney.
Hello. I was just talking with Kathy yesterday about some situations that we've got going on here. OBRA has definitely been a learning curve. I've been our coordinator here in Sanilac County for, gosh, probably like 3.5-ish years. And there's constantly new things where I'm emailing the team and I'm like, I've just got some questions. So definitely, if you guys have any questions, I would encourage you to reach out to your local CMH and get in touch with the coordinator there, and they usually do their best to try and answer those questions, or like they can get in touch with Kathy or the other OBRA teammates up at the state level and try and track down the answer for you.
We have within the office, we have, thank you, Courtney, too. We have, there's 3 of us that are on the clinical team, and of which I'm one. And we just hired a help desk technician, which we're very thankful for, because we were all sharing that duty when we went, after we've gone live. And when we first went live with our electronic referral system, we were getting over 100 emails a day. So we have Yvonne, who does our egrams work, but we're a very small staff, and we're looking to grow. But right now we're small, and wearing a lot of hats and doing what we need to do. The other thing that I do in the office, I handle all the appeals. So, and I do all the Medicaid recoveries. So I get to be the bad person, but I laugh about it. I say, I work myself out of that job in a heartbeat if I could help training and helping people be compliant, and the nursing homes do what they need to do, make sure they're in compliance and that type of thing. So we work hard at making sure that happens. So, but as Courtney said, there's so many nuances to OBRA. It takes a long time to really grasp and understand all the little nuances and what we call the gray areas of how we do what we do. But why it is that way is because we look at each individual and we look at their unique needs and what's going to be best for them. And we do not, we don't blanket, this, everybody in this area does this. We look at each person as an individual and look at what, bottom line, what's in their best interest. And that's how we make our decisions. And we encourage all the OBRA staff around the state to do the same. And Courtney, you could probably back me up on that. You've probably heard me say that before. And it's just, how I was taught, and by the OBRA coordinator, or our manager that we had before. I shouldn't say OBRA coordinator, but she was at one time in Lansing. And but Michelle retired a year ago, and she kind of oversaw this group, OBRA group, for many years, both working within CEI, CMH, and then at the state level. But it's a great position for me. I love the work I do. I'm very passionate about, making that difference. But, it's again, I just reach out to everybody. I know we all do in our way, or you wouldn't be watching this webinar today.
Does anyone else have any other questions for Kathy?
I did drop my email address in the first slide, I think I did. So anybody wants to reach out to me afterwards, please do.
And
Be more than happy to.
I will send out your PDF, your presentation, and I'll send it out to everyone on here, as well as we'll get this edited and up on our YouTube channel for the Mental Health Association in Michigan. Thank you, Kathy, for being here today. This has been great information, and we appreciate your time and your knowledge to be here. So thank you.
Anytime.
Yeah, absolutely. Coming up next month for MHAM, we are going to have an in-person event at Hope Network, which is in Grand Rapids. And what MHAM is looking to do is doing some town halls around the state. And this is going to be our very first one. And we will be focusing on navigating the community mental health system. This is a free and open in-person event, nonpartisan, to the public. So if you want to go out on our website under the events tab, you can register for that. That'll be from 6 to 8 p.m. on February, Thursday. It's February the 16th. So we hope to get as many people as there. We're going to have some free community resource tables. So if any of you are part of a mental health organization or know someone that would be interested in a complimentary tabletop, we would love to have you. You can reach out to me. So thank you again, everyone. Have a wonderful rest of your day and a great weekend. Stay safe.